Welcome back after lunch. The session this afternoon picks up on some of the threads of the discussion this morning. So we're going to talk about inclusive design and we're going to talk about care systems. So we have 3 different talks as part of that, and I'll introduce the speakers as we go. And what we'll do is we'll let them speak and then we'll have the panel session at the end as we've had in the previous sessions. But the first speaker has additional duties. So it's a real pleasure to invite John Aston to join us, who's been well known in the university for some time, but he's now the Pro-Vice Chancellor for Research in the university. And that is a delight for those of us who are academics in the University of Cambridge. And we're going to ask John to come and present a couple of prizes first and foremost, and then he'll give his own talk. And he's been fully briefed, so I'm going to say no more, but just welcome you, John, to the stage and let you crack on. Thank you.
Thank you very much. In actual fact, you really want to save the applause for our prize winners. So it gives me great pleasure to announce the prize winner of the Early Career Research Competition, and that is Akewumi Akimbola. Dr. Akimbola is a Nigerian medical doctor who completed his MPhil in Population Health Sciences here in Cambridge through the Cambridge Trust and King's College funding. He has won so many awards that if I read them all out, we wouldn't have time for his talk. So what I'm just going to say is it's a really great pleasure and congratulations on winning your award.
Thank you very much. Hi everyone. Am I quite audible? Okay. Thank you very much. So, my name is Dr. Akewumi Akimbola. I am a Nigerian medical doctor. And I just completed my MPhil in Population Health Sciences at King's College, University of Cambridge. And so I'll be presenting my topic, comparing complete case analysis and multiple imputation techniques in estimating hepatitis C prevalence in people who inject drugs in the United Kingdom. So let's imagine that there's a disease outbreak, and we've been asked to collect data. And at the point of analyzing the data set, you realize that about 50% of the data set is missing. What would you do at that point? Would you remove the entire 50% missing data, or you would want to find plausible estimates to fill in the missing gaps? And let's not also forget that when you remove the missing gaps, especially in a data set that has very large percentage of missing values, your sample size drops, and then you tend to also lose statistical power, which in that case, you wouldn't trust the results and findings of your analysis. Right? So this brings us to 2 important concepts in statistics and data analysis: complete case analysis and multiple imputation. In complete case analysis, you remove the entire missing values, while in multiple imputation, you write codes, and the codes through R, using the MICE package, finds plausible estimates that would carry the original variability and uncertainty that the original value would have carried in the data set, and then it fills the missing gaps, and then you have a complete robust sample size, and at that point you can trust your statistical power post an analysis. So my project used the data set from the United Kingdom Security Agency for hepatitis C surveillance data, and this is the methodology that we used. So first of all, I have a data set. The first thing I did was that I checked for the missingness pattern in the data set. Now there are 3 types of missingness pattern: missing completely at random, missing at random, and missing not at random. So I used the Little's MCAT test in the Narnia package to ascertain if the missingness pattern is missing completely at random. Right, and interestingly, the missingness pattern in my data was missing at random. And so there's a rule of thumb that if the missingness is missing completely at random, you want to tend to use a complete case analysis. And if it is missing at random, you want to use a multiple imputation. So interestingly, for my data set, I am supposed to use a multiple imputation. But for the purpose of my research, and because the core of my research was in comparing the 2 methods, I had to use the 2 methods on the data set. So I took the same data set, I duplicated it. On the first duplicate, I did a complete case analysis. And in 7 duplicates, I did a multiple imputation technique. Then I compared the outputs of the analysis across all of the listed entities, and then I compared, most especially using indices like the p-values, confidence intervals, and odds ratio between the two methods. And then, and then this was the first plot that I got. And so the first plot there is from the analysis using the complete case analysis, which shows the trends in hepatitis C prevalence over 10 years, right? And so if you would look at it with me, between the year 2013 and 2016, there was a very sharp increase and also a sharp decrease in 3 years, right? And I look at the corresponding plot here, which is the multiple imputation plot. In 2013 and 2016, that sharp increase and decrease was not there. So this only tells us one thing. Using the multiple imputation technique, I have a more accurate plot with me. So the complete case analysis kind of exaggerated the plot between those years, probably because of the impact of the missing values. Right? So this plot shows that this multiple imputation technique is actually accurate. And one of the ways that I can also know that it's accurate is because between the year 2017 and 2019, there was an increase, right? There was a spike. So the spike is also present here, but it's not as exaggerated as in that one. So for the first plot, the spikes is a result of the impact of the missing values that was in the data set. And then now looking at this table, I mean, we have the variables I worked with, some of the variables, and then we have the output, and then I have on different columns, I have the output of the complete case analysis and the multiple imputation. But one thing that you would realize is that the confidence intervals across all of the variables in the multiple imputation is narrower. And in narrower confidence intervals can only demonstrate more precision and more accuracy. And so even for the last two variables on the table, complete case analysis output said the association was significant. But after using the multiple imputation, the association was not significant. And so it shows that the complete case analysis could have introduced discrepancies in the results that the multiple imputation technique could account for. And so what is the eventual conclusion of my research? Is the fact that the multiple imputation approach is actually an approach that allows you to maintain the robustness of your sample size. And thus, so you can, at that point, you can trust the accuracy that it would give and the results that it would also provide. And in comparison to the complete case analysis, right, you can be sure that your estimates are not over-exaggerated. And I think this process can be expanded or can be utilized and picked up across several public health and epidemiological research. Thank you very much.
So we're going to go from national level down to local level, to hospital design. So we've got a double act now. I don't know how this is going to play out, but we've got Ian Hosking, who's a technology consultant, come design researcher, an expert in inclusive design, and particularly in areas around visual stress. And we have David Rowich, who's a paediatrician and development neuroscientist with a particular interest and responsibility in the new children's hospital up on the Addenbrooke site. So the two of them are going to talk about, they're going to tell me what they're going to talk about, but it's about precision medicine and visual design of hospitals and a case study of that particular hospital. Please.
Thanks very much, John. Thanks very much for inviting me to this very interesting precision health symposium. So hopefully our purpose will be clearer as we go through. I'll tell you about the Children's Hospital, and then we'll come back in Ian's presentation to answer the question, what's wrong with this picture? So Cambridge Children's Hospital, as people may know, is a new development on the Addenbrooke's campus. It is more than just a sort of shiny box. We're really trying to bring in some innovative healthcare pathways that don't exist in the field of pediatrics. One would be integration of physical and mental health, which people might understand can occur in children with cancer who are vulnerable to depression, for eating disorders, why you might want to have a psychiatrist and a pediatrician taking care of the patient at the same time. That will be the care model of Cambridge Children's Hospital. Removing stigma by designing rooms that are universal so they could handle either patient. You wouldn't be able to tell just from the hospital room necessarily, is it a physical or mental health patient, intentionally to remove stigma and also normalize the incorporation of mental health into our care plan. Research. It's the University of Cambridge, after all, so 5,000 square meters research in the hospital. That will be departments of pediatrics, psychiatry, obstetrics, engineering, etc. It'll be multi-departmental. We'll have research in the hospital engaging patients, and also the hospital will reach out into the region to work with other NHS trusts to provide population-based research. And a school in the hospital with programmed 40 staff, so that children coming into hospital can maintain their school studies, have treatment in their room, have treatment in special classrooms, and of course we will have educational needs children coming to the hospital. So maybe just to sort of focus on some of the areas of impact where we think this hospital will be special, to talk about prevention medicine, as that's the topic of the day, special educational needs and disabilities, which you've heard mentioned also earlier as a concern, and life sciences, which means how would this hospital work with industry to actually create more opportunities for advancement. And here's a slide that we use as sort of a entree to our approach to thinking of prevention medicine in pediatrics. So this would be, our patients they're possibly, I guess you could say, preconceptual, if we think about, preconceptual screening, looking at issues that could occur in the womb. As a neonate, we are now moving towards a newborn screen pilot of a whole genome. How will that give us a sense for either immediate or distant health risks. And all these question marks pointing back really are speaking to an ambition that the pediatrician of the future will take as their job: adult onset metabolic disease, renal disease, cardiovascular disease, maybe even dementia, to the extent that those have origins in children, young people not to 25 years of age, which is highly likely. Then the job of the pediatrician becomes to understand who deserves screening and then how to create stratified interventions for those patients. So this is very much aspirational, but some of our research is already pointing to where biomarkers are highly predictive of early childhood outcomes. Then the bottom is not just thinking about physical and mental health, but actually extending to school, and why is that so important? And again, we heard this data earlier today about the rise in educational health care plans, which are educational health plans, which are for special needs assessments, and why Department for Education is so concerned because of the 10%, 20% rise in the request for such evaluations, which then goes to local councils and putting great stress on local budgets. What can be done? We sort of have these rising rates, and we don't have a plan to sort of more effectively identify kids at risk for special educational needs or perhaps failing school readiness. And if you look at the outcomes on the right-hand side, they're very concerning associations. When you fail school readiness, a child at age 5, not only is their school trajectory impacted, but also later life longitudinal studies show how significant that can be as a marker or a primary outcome we might use in our research to try to do better. Can we identify those children at risk? Can we provide stratified interventions? And that would be, again, I think how we would like to think about a hospital is not just about health, but also how children can return into society. So how are we also using data science, which is, as I agree with Ron and others, critical. And the recruitment of our population, which across the east of England has minimal ascertainment bias, and so we obviously monitor our recruitment to clinical trials by index of multiple deprivation to be sure that we are representative of the population. But going forward, we expect that many kids coming to hospital, our specialist clinics, will have genomics and through research other biomarkers. Patient wearables, all of this was discussed before, so I don't really have to spend very much time on it. But the data links are incredibly important, and I think where we're seeing some real interesting successes now is in the east of England, linking genomics to the hospital record, to GP records through the Eclipse platform, and then also we have an ONS portal to be able to look at educational outcomes. And that puts us in a position to answer these sort of big questions on the right-hand side, which have to do with, can we identify those reliable biomarkers and shift towards more of a preventive approach? Can we understand basic causes of disease, where we'll also bring in a lot of the basic science assets of the University of Cambridge across departments? And then finally, showing direct benefits to the subjects, which is so important in our research in pediatrics. We always want to deliver a diagnosis back, provide as much good medical advice as we can. So we bring we bring clinical returns into our approach to research. That helps to show impact, it helps to engage the public, it also helps us to understand how what we might be doing could be implemented and scaled across the NHS. And then on the left hand, the blue boxes are just where industries are actually providing us some of the tools as well. They're not just coming from investigators. So I think there are a couple of impact cases. Working with Illumina, we're bringing whole genome sequencing and ultra-fast whole genome sequencing into the picture. And this is baby Oliver, who was in the BBC. He was born with a big tumor on his thigh. He would have had chemo, radiotherapy, and surgery. He would have spent his first year in hospital. And the parents would not be smiling at the end of that, because that's sadly, the aggressive treatment that was required for a biopsy that was inconclusive and could have been a highly malignant tumor. The genomics, however, was reassuring. So we did nothing and just watched baby Oliver, and the tumor spontaneously regressed at a year of age. We've had a second case just like that too. So genomics actually, this is precision medicine, but unless it's more precision medicine, we would have over-medicalized that patient. But it's also where tools coming from companies like Illumina can really be helpful in our research and care. And then this is baby Opal, child who had congenital hearing loss and received a adeno-associated virus gene therapy produced by Regeneron. Her parents, understood that she was hearing for the first time in her life. So, very exciting things happening in pediatrics. Some of these are opportunities that come through working with industry. That actually is something we give credit for as a life sciences strategy. So we think that working with industry is encouraged for the NHS and for our working in the hospital. I won't go into this slide in detail, but just to say there are many causes of death and disability in children, young people, mental health, a serious concern, especially in 16 to 19-year-olds, cancer, genetic disease, and you can go around the circle and recognize, major diseases. The approach that we're going to take will be setting up research centers to focus on these, but also encouraging our investigators to think about early origins. When would you screen such that you could pick up a disease process much sooner? If it's mental health, what is required to surveil for earlier detection of mental health? Because there is evidence that the sooner you treat for depression, the more effective that treatment can be. So that will be a sort of an overarching theme, the predictome at the center of the slide. And how we might imagine this might be brought into a care plan, and this could be more general for pediatrics, but does reflect our approach in Cambridge, would be looking at techniques like whole genome sequencing, and a newborn screen pilot for whole genome sequencing has started in the East of England as maybe a starting point. Taking advantage of existing data assets. So we do have health record data. We do have in the East of England, all GPs are on System 1, one electronic health record, and the Eclipse platform run through NHS prescribing gives us access so we can actually distill or obtain those health outcomes, look at the association of genetics or deprivation, communities, and disease trends. We can make those links. I know there's a lot this is a big aspiration for many in the room, but we're seeing it work now, and maybe because the East of England is a bit more homogeneous, we're seeing some very good progress. And then the educational record, I think a key outcome for our research increasingly will be for young children, are they school ready? And if not, how could we power interventions to maybe be more effective at supporting children to succeed in school readiness assessment? Then in adolescence, we'll think about other diseases, if not before, cardiovascular risk, who goes on statins, and so on. So I think pediatrics of the future, I'd like to think, will be a place where we can make effective insights into disease risk and also interventions that can maybe have long-term impact and really demonstrate some of the benefits of prevention medicine. So this is not an ambitious hospital at all. We're just a regular hospital. No, just kidding. We do think research is going to be critical to deliver on these promises. There are 3 planks of the Children's Hospital, which we call whole life, which is to say, can we take pediatrics and sort of expand its scope to include, middle age and even, elderly. Whole community, where this is a regional hospital in the only area of England without a specialist children's hospital. So our commitment is to support Peterborough, coastal deprived communities through research, teaching, and also as a hub for specialist care that can extend to community. And then the whole child, which is the way that we think about integration of physical and mental health. And also now we have to think about the building itself. If we're having children with autism or other conditions that might result in sensitivities to environment, how can the hospital fabric be designed to accommodate them. So this is where I want to introduce Ian, Department of Engineering, who has been providing us some really fascinating insight into the way to design a hospital to make it more comfortable for our patients.
Can anyone help me find my slides? I haven't seen this laptop. No, definitely not. As my presentation is about visual stress, not having slides is quite stressful, let's say, right? Okay, I'll make use of the time. Firstly, I'd like to thank David. He gave me unwavering support when this was just an idea, which frankly was a very ambitious idea. So it's easy to be supportive when things have progressed, but he's been unwavering support, as is Tom Bashford, who's sitting at the back. Having that backing and then having an amazing team, including mathematicians, etc., to do what we're doing. So what is visual stress? Well, this thing here, our kind of grey blancmange inside our head, is roughly 2% of the mass of our body, but consumes about 20% of the energy of the whole body itself. So it's not very heavy, but it's very power hungry. So if we go back in time, and a great kind of Cambridge story, I'm living here by the way, Charles Darwin gave us the theory of natural selection amongst other scientists, and our visual systems have evolved to be incredibly efficient to process natural images. So Horace Barlow, who was the great-grandson of Darwin, came up with the understanding of sparse firing in the brain, particularly in the primary visual cortex at the back of our head in the occipital region. It's incredibly efficient at processing natural images, and that energy efficiency is important not only in terms of the neurons in the brain, but also in terms of the overall energy consumption of the body. Then what we do is humankind has created images that statistically deviate from natural images. Oh, good. And this will help us explain how can we analyse essentially the container for all these precision medicines within the hospital. Good, we're going. So we developed a tool called Vista, and this is a genuine health warning, okay? I'm about to show you some black and white stripes, okay? For some of you, you're going to look at it and go, they're black and white stripes. Thank you very much. Next speaker, please. Some of you are going to find them uncomfortable to look at, and if you're aware of your own position, this can be epileptogenic, so it can trigger seizure. I'm not going to show them for very long. If they're very uncomfortable to you, look away. And if they're not uncomfortable at all, then I told you that they may not be uncomfortable, because this varies across the population. So these are black and white stripes. So some of you are going, these are black and white stripes. Some of you will find that these are shimmering. Some of you might see a shape in there. Some of you might see colours and other visual distortions. It's dependent on the size and the viewing distance. But what we find with human-made things is these kind of regular patterns are everywhere. So this happens to be the front of the school. So what I've just shown you is one of the most uncomfortable images that we can create for the primary visual cortex. And then we build things like this. And we've analysed this. And what you realise is there's a no-cost solution to this, which is this, yeah? But because architects are not aware, we end up building things with these regular stripy patterns, like this, which is a 50-50 duty cycle, roughly the range, although the contrast is not that high. And what we're seeing is there are certain architectural features, particularly acoustic panels, for example, and often carpets, that produce these high contrast images that for some people can be epileptogenic. So Arnold Wilkins, who took on the work, who understood the work of Horace Barlow, the first case he came across in the 1970s was a Victorian-style radiator, which was triggering seizures in a patient. So this can be highly serious, but it affects all of us. Just to show how precise this can be, some people have reading-induced seizures. There's a case study in the literature of a lady who had font-specific reading-induced seizures. She had identified the fonts that were triggering seizures and those that weren't. If you read the paper, you can see the clinician thinking, So they wired her up with EEG, and they confirmed after about 3 minutes of reading that she was having seizures. And we can actually analyse these fonts mathematically and start to understand the statistical properties that can lead to this visual stress. So what's going on here? Well, one way of understanding it is this image at the back of King's College Chapel. On the top half is human-made structures, which are highly regular, and then the bottom half is nature. So when we look at nature, they have 3 very important properties. They're basically not stripy, and we can measure that using things like Fourier analysis. The colour contrast is relatively modest, so the combined colours like the daisy head there. And basically with normal light, the sun doesn't flicker unless it's occluded. I've already tested the lights in here, and these do flicker. It's invisible flicker. It's mains rectified 100 Hertz flicker. But in nature, it's not stripy, modest colours contrast, and a constant light source. And then we do this. And essentially, we've created a visually toxic world, which for most of us doesn't bother us. But for some people, it completely blights their lives. So we know of a case study in the US that we're following of a lady who has to walk around with welding goggles on and a hat to survive modern lighting and modern displays. And we need to be very precise in our understanding of this and very precise in the environments that we build to avoid this happening. So when we look at these things, we see these regular stripy patterns, often high, strong colour contrast, but not always. Very tempting in a children's hospital, because children like bright colours, right? Do they? Is that always the case? Because it could be severely visually stressful, and flicker is pervasive and it's everywhere. So particularly with LED lighting and dimmable LED lighting, which is pulse width modulated, we create flicker. It's headlights in cars, it's lighting in this room, and displays flicker too. And it's visually toxic, but to a degree hidden because of the complexity that underlies it. So what we see here is that we can have a very precise mathematical understanding of this statistically in terms of its spatial, chromatic, and temporal characteristics. We can see how people perform under these conditions and their preferences, for example, things like fonts and colour choice. And we can measure, we have correlates in the brain, so things like near-infrared spectroscopy, we see a heightened hemodynamic response in this part of the brain. In other words, more energy is required to process these kind of images. And that is more extreme in people who are susceptible to visual stress. So that's an incredibly elegant model. But we have to be careful. The maths is very precise, but it's a proxy measure for how humans may respond. So we mustn't overinterpret this precision, which is actually a kind of real problem when we're designing these tools. So how do we take this complex thing and translate it and put it in the hands of designers so that they can be aware and modify their designs? And that was the challenge. So let's kind of move ahead. So we've got a scientific understanding, but how do we put that in the hands of designers? So what we aim to do, this is what this project, which was funded by Adam Boots Charitable Trust, was to be able to analyse in 3 dimensions, so using video, independent of the architectural tools that we'll be using in the design, a few simple steps to analyse, and an output in pictures, not just numbers. Talking about the residual from a Fourier analysis does not go down too well with architects, which I don't blame them. So we built a web-based tool, which is in prototype form. We got an incredible team on it, and we got an incredibly talented engineer from the engineering department who's actually visiting here today. He basically knocked it out of the park in record time. And what we're able to do is drag and drop images and videos in. It deals with all the scaling, all the maths, and comes back with a heat map. So that was the school I showed you earlier. I'm not sure whether this will work. This is a video. Is it going to work? Yeah, okay. So this is just me with my phone. Video walking up to that school that I showed you earlier. Okay? And hopefully this will work because it's Right, so what we can show you here is we analyse it frame by frame. So we can go to where the peak is in walking, so it heat maps that. So we can see that peak area on the left. So that's a peak visual stress for walking towards this building, because it's very scale dependent. So the contrast sensitivity function in the vision peaks at 3 to 5 cycles per degree. So we have to understand scale and viewing distance. And then there's a secondary peak you see here that goes to the video. Hopefully I'll get that to work. So you see as you come in here, as I turn with the camera, you see this peak occurring here with these gratings in the thing. So we're able to essentially analyse from different distances through time in this building, so we can start to analyse it. And so here are some images from the Cambridge Children's Hospital. So we can take them, we deal with all the scaling automatics. So basically you drag and drop the image on, a few little complexities, and it comes back with a heat map and a score. So these are the heat maps for these different images. So on the left, we see the 3 lowest scoring images, and the good news is the ward bedroom is currently the best scoring image, which is kind of reassuring. And of course you have to think about this a little bit, because if I'm in a room laying on a bed, suddenly the ceiling becomes a more important thing. So if I've got a vent in the ceiling, which is black and white stripes, for its venting, it can be problematic. Now you kind of get that stripes are a problem now, so you're not surprised that on the right, there's a lot of stripy elements in here. So the one in the middle actually is the reception area, which has already been redesigned. So we all, and this is like hot off the press because I've been doing the reporting this week, but we've already got redesigns where we're seeing a significant reduction in the scoring of this, particularly by choosing different acoustic panels. And so that's kind of very encouraging. We've had amazing support from the architects and the team around that. So there you go. So that's one. Venetian blinds are a bit of a challenge, so we have to look at different lighting conditions. So we're kind of worried about Venetian blinds, but it's a systems problem, so there are kind of, unfortunately, ligature issues if you've got roller blinds and things like that. And then there's a debate about these acoustic panels and stuff, which is kind of ongoing in that process. So the nice thing as well here is this is the redesign of the atrium at the front. So this is this castellated acoustic panelling on the left, and it went from being the 2nd worst scoring to the 4th best scoring on the redesign on the right. So we can be precise with these tools mathematically, but we have to interpret them with care and understand that there's a range of things in terms of viewing angle, etc., and how the context of use. So in conclusion, we've gone from relatively complex science and mathematics to putting basically, this will run on your phone, so I could have taken a picture of this and run this through, and basically put precision understanding in the pocket of an architect so that they can understand and do that. I'm conscious I've probably run over time. Are there any questions? Have we got time for questions or not? We've got panels. Okay, I will shut up. Thank you very much.
David, Ian, thank you very much indeed. So that was a local picture. We're now going global, back to the big scale. So I'm going to invite Ros Parks-Rutanchi to come up and talk about opportunities and challenges for precision public health in low and middle income countries. Thanks, Ros.
Thank you. So I realised that when I came up with this title a long time ago, I thought I'd be able to cover this topic, and then writing it, I realised I'd had to focus down on something. So I'm going to give you some examples of this from HIV, which is my area of interest particularly. So over the last 25 years, when we've had massive scale-up of HIV treatment, the WHO and the global community has used a public health approach to HIV treatment for the majority of low and middle income settings. So what this means in actuality is that we have a standard first-line drug that everybody takes across a country, across a region, most of Africa. People who have started antiretroviral treatment will be on this one pill once a day, generically made in low-income countries, the cheapest option, but also easy to take because it's one pill once a day. And if you fail on that, if you get virological resistance, you then move on to a standard second-line treatment. And what this does is keeps the cost down, but these are very effective. They have very good virological suppression due to the fact that there is 3 drugs in there all acting together. And what we've managed to achieve with this is a huge success of getting millions of people across the world onto HIV medicine and really having pretty normal life expectancies. But as we, are here, we know that there might be some challenges with this public health approach. So what the kind of global strategy in HIV epidemiological control is now, and I'm sure most of you have heard of this, is to get 95% of people now tested for HIV, of those 95% on treatment, and of those 95% virologically suppressed. What this means is both the person receiving the treatment can have a near or normal life expectancy, but also they will not pass on the infection to others, either to their sexual partners or mums to their children. And so that's our goal, and we're achieving this. In the UK, we're doing very, very well. We're hitting our 95s. But there are pockets of people around the world who are not getting anywhere near that. So the first column, and this is UNA's 2024 report, so recent report, we've got only 48% of children being virologically suppressed in those under 14 years. Women, we're on about 78%. And men, we're doing worse, on about 67%. And that's global numbers. So we're not getting to the last kind of 20-30% of people with our public health approach. On top of that, other way around, on top of that, there's particular groups that are having even more challenges. We tend to call these key populations, and they might include people like sex workers, men who have sex with men, people who inject drugs, and transgender people, and also prisoners is another group here. And what we're finding around the world is that there is huge amounts of stigma and discrimination for these groups. In my work, where I work in Uganda, for example, the country has introduced the death penalty for aggregated homosexuality in the last 12 months. So we're having increased punitive laws against people in key populations. And what this is showing is that up to 30% of those groups are avoiding health services because of stigma and discrimination. So there are pockets that this public health approach is not working for. On top of that, so, we've got a problem. We're spending $3 billion over a couple of years on drugs. So our simple regime, our first-line medicine, is still costing us billions of dollars. And what the second graph is showing plateauing of HIV funding. So despite the fact that we continue to put more and more people on drugs, more and more people getting treated, we have got plateauing of funding, and the estimated gap in funding for 2025 is about 30%. So we're not going to be able to give people more expensive, more precise drugs. Right? We just can't afford it. We can't afford to do this. But what can we do to narrow that gap between the people who are doing well on the public health approach and this gap of people who are actually us not treating them and not providing them what they need is perpetuating the epidemic and driving the epidemic. So this is my ideas from the work that I've been doing of what we might be able to do, and there's lots of work around this going on, but just to categorize it, and I'm going to give you examples from each of these groups. So we can personalize the access to care. So for those people who are doing quite well, who are doing well on their first-line drugs, can we keep them doing well? Remember, this is lifelong treatment. They need to take these drugs for the rest of their lives. So can we get them, can we personalize it in terms of where and how and who delivers the care? That might save us some money. So then with that money, can we do something to help those people in more vulnerable groups, the groups that we've talked about? And I'm going to talk about another group that I work with, which in Uganda we call mobile men with money. So these are people that are often away from home, work in a cash economy, truck drivers, and for me, fisher folk, who are also, tend to have high HIV positivity rates. And then we get to some precision medicine. We are increasingly seeing cardiovascular and metabolic disease in low-income settings. There's still a lot of HIV and TB co-infections, hepatitis co-infection. We had our presentation earlier on about hepatitis as well. This group probably does need personalization and precision medicine. They need different antiretroviral drugs. They have a different profile. But not because the drugs are not working on their virus, but because their side effect profile means that the drugs may put them more at risk of these long-term effects. So this is taken from a recent paper by some colleagues of mine, and it actually was looking at digital health for antimicrobial resistance. And they categorized different digital tools and had personalized medicine as a separate box at the end. I don't really agree with this. I feel that actually personalized medicine can rely or can take activities or use innovations across the whole spectrum of digital tools. And I'm going to give you some examples on why I think that is. So just a snapshot of HIV in Uganda, 1.5 million people. We are having about 50,000 new infections per year. A lot of these are in young people, so adolescent women and girls. And, we have the same problems as many low-income countries. Lifelong treatment, lots of drug stockouts, and hard-to-reach populations. So there is a concept called differentiated service delivery, and this was the kind of first attempt globally by the global population to start to bring in personalization to HIV public health control. And this is about trying to deliver the service where people might be able to access it best. This is a document from the Ugandan guidelines, and it's a bit small, but basically you can kind of see that there are options for how people might access their treatment in the facility and how options that people might access their treatment in the community. And we did a piece of work around developing a tool that would enable people to pick up their government drugs. Oh my goodness, 2 minutes remaining. I've got to go very quickly. To pick up their government drugs in a private pharmacy. And this was developed by the Ministry of Health. And what it allows is stable people to pick up their drugs in a community pharmacy near to their home, which can keep them on treatment for longer because they don't have to spend a lot of time in the hospital. Another tool that we have used is an interactive voice response tool. These are very simple mobile phones that give people reminders for their drugs and reminders to come into hospital. But what is important about this is we have a dashboard that the healthcare workers can see. So we can have people on their treatment, increasing lengths of time in between seeing them, but we get some red alerts when they stop picking up their calls. And what we have found is that there's an association between people stopping picking up their calls and then dropping out of care. So we can proactively contact people if we see that they're not taking their drugs so well, so that when it comes to their appointment in 3 months' time, we haven't lost them entirely, they haven't disappeared out of the system. We did this study in a group of young people, and importantly, we gave them all a telephone. So this was not the effect of the telephone, and both the control and the intervention arm, they got a phone. And what we saw was an improvement to 91% of people being virologically suppressed compared to the control arm of 77%. We're also doing a medical drones project. What this is trying to do is to get to the fisher folk. There are 3 health facilities on 84 different islands in Lake Victoria, and people find it very difficult to travel to health facilities. We are using this little, not very expensive, low-cost drone on the right-hand side with a 3D printed box, which carries 6 sets of drugs. We've been running it to these 5 sites over the last couple of years. And what we do is we use this lady who is a peer support worker. So she's a lady who looks after 7 different people in her community, all living with HIV. And we've taught her to approach the drone, unpack the drone, and to look after her colleagues. And our qualitative research indicates that the community is very comfortable with this and that it's starting to reduce drug stockouts. We're actually undertaking an RCT of this at the moment. And then the last intervention that I want to talk about, just touched on briefly, is AI within this group, or machine learning. So when we rolled out a new first-line treatment, including dolutegravir, it was a change in class. Our very large clinic started to notice that we were getting a lot of hyperglycemia in our patients, so we started to analyse why this might be. And there's a particular phenotype who's been on drugs for a while, access to different types of antiretrovirals, that were likely to develop type 2 diabetes. So we took this data to develop an app so that we can screen for those people who may not want to start on the standard first-line medication. Just to talk about challenges in the last 20 seconds, it's all very well talking about these things, but we have to remember the challenges that we have. This is what most of our medical records look like. We do not have EPIC. So we can talk about data, we can talk about genomics, we can talk about precision medicine, but we need to do something structurally about the fact that, you know, we have records that look like this. Our clinics are overwhelmed with people. You can see the nurses are trying to do what they're doing with stuff on their lap. Even taking records, even collecting data is very challenging when you're in that environment. And so we have to be aware of the situation that we're in. And internet access. You know, a lot of these things rely on us having stable internet. If you don't have much internet, you know, we've got structural problems of how we do things. And just one last slide is we have a network of AI and maternal sexual reproductive health, and we've done some qualitative work to try and understand what healthcare workers think about AI and what they understand about it. And so this picture is a kind of informal settlement on the left-hand side of the road and a nice middle-class area on the right-hand side of the road. And people talk about, you know, the differences in who uses precision medicine, who is going to get to use AI. So people have said it's going to take us a long time to appreciate these things. These things are mainly for the foreigners. We think you need to test it more first. But then we've got some people, like on the bottom of the right-hand side, who's saying, I'd rather go to somebody, anyone, even if they're not a person, because I might be able to get help from them. So it doesn't really matter how you deliver the support to me, even if it's an AI bot. If it's going to help me, I'll take the help. And then, you know, there were people that were saying, you know what, if you package it in the right way, I think Professor John, if you package this in the right way, teach us how to do it, we'll be able to take on board these things. I'm sorry that was such a speedy run through, but I hope it made sense. Thank you so much.